Hello and welcome to Budgeting and Managing Fiscal Resources. My name's Latanya and we're going to be talking about budgets. So a budget is a quantitative statement, usually in monetary terms, of the plans and expectations of a defined area over a specified period of time. So that's a blanket statement. We're used to the budget being, this is how much money we make a month, this is how much money it costs to live a month, and then the everyday person uses that to tell how much money we can spend on, quote, fun things. When it comes to medical budgeting, it's a little more in-depth than that, because there's a bunch of different types of budgets that they have to work with and plan from, and kind of guess how much revenue they're going to be getting for the next year. So they use budgeting as a process of planning and controlling the future operations by comparing their actual results with their planned expectations from the year before. There's a couple different kinds of approaches, and forgive how wordy this slide is. This is the one that's the wordiest. With an incremental approach or a line-by-line approach, the finance department distributes a worksheet with an expense item on each line. So this would get super long in huge companies. You might see this more in like per patient. So like when a patient gets discharged home, they might have an incremental or line-by-line like statement saying this is how much everything that we did for you cost. It would be really difficult to do a line-by-line for a total healthcare organization. It would be very long. A zero-based budget assumes that the base for projecting next year's budget is zero. So assumption is that you're not going to spend any money, and then when the managers do spend money, they're required to justify all the activities and programs. So each time they spend the money on something and they need to re-ask to spend the money. For instance, let's say last year we spent the money on, so many IV fluid bags. So this year, instead of just assuming that we're going to use the same amount of IV fluid bags, they would need to re-ask and revisit, do we need that many? Did we need that many last year? Before getting accepted. In a fixed budget, the amounts are set without regards to change that may have happened during the year, so you don't really pay attention to patient volume or like programs or activities that have had an impact on the cost. So that kind of budgeting normally comes out lower because you're assuming that patient volume isn't going to go up. You're assuming that inflation doesn't really happen. So a fixed budget is more rigid. Variable budgets are developed with the understanding that adjustments to the budget can be made during the year based on changes in revenues, the patient census, utilization of supplies, and other expenses. So if we spend too much this month and the census was high, next month we're going to try to spend a little bit less because our census was not as high, and vice versa. So the operating budget is the big one. It is the annual budget, the organization's statement of expected revenues and expenses for the upcoming year. The operating budget is normally coinciding with the fiscal year, so January isn't always the beginning of it, but it is a calendar year, so 12 months. You break that down into quarters, and then some people break that down into monthly to make sure that you're meeting your what you're expecting, meeting your goals. So when the operating budget comes into play, you're talking about revenue and expense. So revenue is what the hospital is going to get paid. People sometimes assume that revenue is what we charge the patients or what we charge for our services, and that not always is the case, because we can charge someone, let's say we charge someone $10,000 for their stay with us, and everything that we've done for them during that stay, the supplies that we used, that's what we charge them, is $10,000. But they're a Medicare patient, and the Medicare comes back and disputes a few of the things that were done because we did a couple things that they needed, but that weren't necessary to the original reason that they came into the hospital. So then we wouldn't get paid for that chunk that we did. So our revenue would not be what we charged them, but it would be what they paid us. And we also need to talk about expenses when it comes to the operating budget. So those are supplies, equipment, equipment repairs. Sometimes we need to rent equipment. And then this is also interdepartmental supplies. So one of my articles did a good job of saying what interdepartmental can mean. So this is like the pharmacy. So the pharmacy will stock our unit with the medications that we need. We use a Pyxis machine, so when our Pyxis gets low on a certain medication, the pharmacy knows. They can see in their computers, and they come and they refill it. But the pharmacy doesn't pay for that. That gets charged to our unit. Another example would be interdepartmental supplies would be central supply. The central supply, so the big stock room for your organization, they come and refill your smaller stock rooms on your unit. But once they drop the stuff off, that is charged to your unit. It wouldn't be taken out of their department. So the salary budget is the personnel budget. This one gets tricky. So it projects the salary costs that will be paid and charged in the cost center for the budget, whatever the period is, the month or the year. There's a whole bunch of variables. This one gets tough to estimate, which is why I have the little balancy guy there. So the first variable is benefits. Benefits, when you're thinking about benefits, this one doesn't wax and wane as much as the other ones, but this is a big one because this is what happens when you have two part-time people working for you and you need a full-time person and the two part-timers leave, but you can't hire a full-time person, and you're like, why not? Because they were both working 20 hours, so now we have enough in our budget for a 40-hour person. Well, that's not the case all the time because you're working the same amount of hours trading two 20s for one 40, but now you have to pay benefits for the person who took the position of the two part-timers. So a lot of times that needs to be approved, so you can't just swap out hours for the people that are working in your unit. It gets a little tricky because you have to take into account in the budget the benefits that you're going to pay the full-time person. Another variable is shift differential. So this one you'd think would be not that much, but it definitely adds up. So shift diff is the people who work weekends, the people who work night shift, basically everyone who's not a 9-to-5er gets paid a little bit extra for the quote undesirable shift. So the shift differential is normally a couple bucks an hour, depending on what unit and the baseline pay for you. Shift diff comes into play when, let's say it is the beginning of the school year. So all of a sudden, all these parents are only bringing their children in on the weekends. So now we have an influx of patients on the weekends. So we need more people to work the weekends. Now we're paying shift differential for all the people that are working on the weekends that maybe you weren't expecting. So the couple dollars an hour, it really adds up if you have a lot of people working. Another variable is overtime. So overtime we are all familiar with, I'm sure. you're sitting at home, you get that call that says, hey, do you want some extra overtime hours? And you're like, I'm not sure, but you kind of do because you get paid a little bit extra. So overtime's normally 1.5 times what you get paid. Some organizations it's 2 times. So the salary budget, you can't really, it's difficult to expect overtime. So a lot of times that's added on, tacked on at the end, the time that you went over, and that's difficult to plan for, and it's difficult to budget in because you don't know what your census is going to be like, how many people you're going to need to work. Our unit doesn't do on-call hours. I'm not as familiar with on-call hours, but a lot of like the cath lab people, some of the imaging technicians, that kind of stuff, they work on-call hours overnight. So you assume that you're going to be paying them a lower over the nighttime. Let's say they get paid $3 an hour for being on call. But then if they get called in, then you need to pay them their actual dollarly amount while they're working. So that can, if you need to call them in 3 times this week and you were expecting to only have to call them in once, then that adds up. Premiums vary hospital by hospital, unit by unit. So our unit does clinical ladder dollars. So if you are higher up on the clinical ladder, meaning if you take the time every year to write down and submit, it's like forms and stories about your nursing for the year and why you're higher up on the clinical ladder than a brand new nurse, then you get paid a little bit extra. And you also, with the salary budget, have to worry about your salary increases for the year. Normally you only have to worry about that twice in the 6 month, like when you review people. So supply and non-salary expenses are also in the expense budget. So they are patient-related supplies needed to operate in your nursing unit. They're also supplies for operating expenses, so that's like office supplies. If you need to rent any spaces, maintenance costs, so the pipe bursts in one room, you have to have a plumber come out, equipment servicing, and this is also paid out of normally the unit's budget. And you need to plan for inflation every year for the supplies anyway. So the capital budget is, the purpose rather of the capital budget is to have the state-of-the-art equipment by replacing what has lived or surpassed its expected life. So capital budget is basically the plan ahead budget, and if you don't have a capital budget, then your organization is going to fall behind, because the capital budget is for renovations to the building, new constructions, replacement equipment, or new equipment that will keep you at the top of the healthcare level. So let's say that you don't have an MRI machine, but you want to be one of the hospitals that can take care of a patient that needs an MRI. So you need to use in your capital budget an to purchase an MRI machine. But then you have to take into consideration, how long is this machine going to last? How much does it depreciate each year? And then assume that your machine, let's say your machine is going to last 10 years, this is the normal. So at your 10-year mark, you need to have the money ready to purchase a new MRI machine. So capital items are normally more expensive, and they normally have a quote expected performance time. So the capital budget is that's what that is for. It's to keep you current. You need to have the money set aside to make sure that your equipment, your more expensive equipment, is going to be up and running. So timetables for budgeting. For big corporations, it's normally 3 to 6 months it takes to make the budget, and they normally come out about 3 months before the fiscal year or the calendar year. So the budgets start at the floor manager level, and then the floor manager moves it up through the managerial hierarchy, and then the executives and the boards need to approve it. So what we normally have at the floor manager level, when it moves up, it gets changed quite a bit, and then eventually it will get approved. But what I'm saying is that the floor manager isn't the end-all be-all. They give you their suggestions and tell you what they think they're going to need, and then it gets changed as it moves up. So the nurse managers are normally the monitors. The executives, of course, are going to be looking at the big pictures and asking the nurse managers why things are not meeting or what they're doing differently. But the nurse managers are going to monitor the closest. And they're a lot of times asked to justify reasons for variances and then come up with action plans to reduce or eliminate the variances that they've been finding. So one of my articles did a really good job at the end here. Let me find it. About outcomes in the bottom line. So this section of this article about outcomes just talks about never events. So with Medicare, Medicaid, and a couple other insurance companies, never events came into play, which if a never event happens, then their entire hospitalization pretty much does not get paid for. And they also talk about the readmitting. If someone's readmitted within 30 days of their leaving your hospital, then they will not pay for it because they assume that is the fault of the healthcare facility. So this really has an effect on the budgets. So the outcomes and the bottom lines are affected heavily by not being paid for entire hospitalizations, not being paid for the whole time the patient's here and all the treatments. So let's say someone's here, their heart stopped, and they're very ill. Their heart stopped. We got their heart restarted. We did the heart catheterization, all that stuff. We put some stents in. So they're pretty good now, but they have low blood pressure. They're in a medically induced coma, on a ventilator machine. Those people aren't turning. So if they get a pressure sore, then everything that has to do with the pressure sore, the hospital will pay for. That's not the patient's fault. Per the insurance companies, therefore everything that is related to that pressure sore, the hospitals pay for. Now, if you go back and look through the research, if someone has a pressure sore, a lot of times their hospitalization is extended by weeks. So that's weeks worth of revenue that we're not getting paid for. So it's interesting reading this article, the bottom line and what they say about the insurance companies and why this part of our healthcare is failing. So some more problems that we have with the budget is, we kind of just talked about insurance disputes. So that's when the insurance company says, hey, wait a minute, did they need that? Or I don't think that was their fault, so we're not paying for it. Or you treated something that wasn't the reason that they came in, so we're not paying for that. Kind of hand in hand goes patient disputes. So the patients say, wait a minute, I didn't want that. Wait a minute, I didn't know I was being charged for this, so I'm not going to pay it. So we also have the patients who can't afford discharge treatments, so we eat the cost for that. Let's say a patient needs a very expensive antibiotic that they can't go home unless they can get this antibiotic. But they can't afford the antibiotic, so we can't discharge them. Because if we were to send them to a pharmacy and they can't pick up their antibiotic or they can't get coverage for it or what have you, then that would be us not meeting their discharge treatment. So we cannot send them home. So we eat the cost for that. There also is problems budgeting with the staff. This is wasting resources. This is misuse of sick time. So calling off an hour before your shift, and then now somebody has to work overtime. So now we're paying overtime hours instead of normal hours, that kind of stuff. So this video is really interesting. It's a news video, but it's about the staff suggestions in this hospital saving the hospital over $14 million to stay on budget. So it's really interesting to watch and to think about, you know, how the trash staff had an idea that saved the hospital millions, and the nurses had an idea that saved the hospital a couple $100,000 here, a couple $100,000 there. It's just really interesting how they all came together and to save that much. And you can pause my video here to kind of take a peek at the budget for this unit. And you can chit-chat with me, leave a discussion on the discussion board. How do you think your unit would compare to this unit? So this is a nursing unit expense budget for a 20 staff bed unit, and this is 2013, and this is all like guesstimating. But can you see a place for improvement for them? How do you think your unit would compare? Just take a little bit to kind of think about it and think about where you think your unit is, and you can chit-chat with me in the discussion board. So I look forward to hearing from you guys. Thanks for watching my video. Here's